Hi everyone, welcome Dr. Ganesh to EPOMEC 2025. We are here today. Tell me about your experience and your impression about the EPOMEC 2025.
This is the first time I'm coming to attending the EPOMEC, and I think it's wonderful. I think this is one of the biggest meetings in the Middle East, and being in Dubai is very convenient because you have flights from everywhere, and from my hometown in Bangalore, it's very convenient, just 3.5 hours to get here. So that's very nice. And Dubai is always nice to come to because there are a lot of things, a lot of activities in Dubai. Of course, the hospitality has been great because the venue and the accommodation, because the Conrad, and it's just a small walk to the venue. And it's very nice that the exhibition also is in the center, and you have to go through the exhibition to access the halls. So the exhibitors also have quite a bit of exposure, and they can actually show their products. And coming to the sessions itself, I think it's a very interesting format because you have 3 channels, and this is like a silent conference, and everybody's wearing the headphones, and then you can actually switch between channels. If wherever you're sitting, you can kind of look at the talk that's going on and then switch to whatever you're interested in. So this is actually a very nice format, and you have a very good array of international speakers, and I think the scientific content has been designed very well.
Yeah. What regarding the topic you cover this year? Can you tell me about overview about the topics you discussed in this event and what you presented exactly?
So yesterday we had a session. It was a Q&A session, and I was a panelist on cornea and refractive procedures, and especially treatment of hyperopia. So I do a lot of laser blended vision, Presbeyond. I myself have undergone Presbeyond 10 years ago.
Interesting.
And there were a few interesting questions. What would you do in a 45-year-old with mild hyperopia for correction? And then the discussion was very interesting. And also we spoke about some aspects of cross-linking. So it was an interesting topic yesterday. It's just a Q&A session. And today I have the deferred live surgery, and I'm actually showing implantation of the Hoya trifocal lenses, the geometric plus lenses, which is again a new design based on differential light distribution. And we find that in our study, the patient satisfaction is very good. Mm-hmm. And tomorrow I'm speaking on hyperopic smile, because this is something that I was involved as part of the global trials. And it's the first time we are having KLX for hyperopia. And we did the global trials on the 500, but now it is available on the 800, and we have just started doing hyperopia. And so I want to present our results and the range of hyperopia they can treat, and then what are the results. So it's quite interesting because hyperopia is always a challenge. More than myopic laser vision correction, hyperopic laser vision correction is always a challenge because you have regression, you need to do your refraction properly, you need to compensate for the regression, you have to develop your nomograms. And of course with SMILE for hyperopia, it's again a little challenging because you have to use a medium cone, a larger zone. You need special instruments that kind of reach deeper, the dissectors, and it's thinner in the center, so you can get breakthroughs and perforations. So the technique of dissection also is very important. So there are few nuances which I will be talking about tomorrow on how to do hyperopic smile.
Excellent. What about the hyperopic smile? Let's start from the indication and selection of the patient. What's your approach in the clinical and real life?
See, the indication, of course, you can treat up to 6 diopters of hyperopia and 7 diopters of spherical equivalent, and up till 4 diopters of cylinder. And with hyperopic smile, what we have found is the stability is better than LASIK, especially for higher powers and younger individuals. I think because the corneal biomechanics is a little different from LASIK because you're not lifting a flap. Also, dry eye is less. But over 3 diopters of correction, you get some amount of regression. So for patient selection, I would ideally like to do about 4 diopters spherical equivalent, maximum 5 diopter spherical equivalent. Above that, you can get some amount of regression. Younger patients, you can also expect some amount of regression, and it takes about 3 months for the results and the vision to stabilize. So you'll also have to advise the patient that yes, the healing time is much longer than myopic smile.
Yeah.
Also, you need to look at the white to white, because some of these hyperopic eyes have very small white to white diameters. And if the white to white is very small, say 11 or sub 11, then what happens is, because you use a very large zone for hyperopic smile, the incision is almost at the limbus. So you may have to kind of shift it from the 12 o'clock position to kind of supratemporal or temporal if you want to accommodate it. Otherwise, you will be at the limbus and you may not be able to access the pocket. So these are all a few of the challenges that you need to look at.
Yeah. What about the result outcome until now?
Results, we find that almost about 75% 20/20 or better. In our cohort, we found that there were no eyes that lost more than 2 lines of best corrected vision. You have a small percentage of eyes, maybe like about 8% or so, who may drop 1 line of best corrected visual acuity, which is expected in hyperopia, because you have some amount of induced aberrations with hyperopic LASIK or smile, and then you can have a little bit of loss of best corrected vision. Coming to the centration is very critical for hyperopia, and many of these hyperopic eyes have large angle kappas. So you need to be aware of the angle kappa and center on the visual axis. Of course, with the VisuMax 800, you have central line, so you can align exactly on the visual axis. So it's so much better, and of course, cyclotorsion compensation with the OcuAlign software. So these are all things which are kind of helpful in the 800. And in the 500, it used to take about 35 seconds to do the hyperopic smile, but it takes less than 15 seconds with the 800 because it's a much faster engine.
Yeah. Let's talk about another topic, which is keratoconus. Tell me about your approach in borderline and in early keratoconus patients.
We have a lot of keratoconus in India, as you have in the Middle East. So what is very important is most of these patients are picked up when they come in for refractive surgery. So when we screen them for refractive surgery, we pick up these early keratoconus or form frustrated keratoconus, and they are not comfortable with contact lens. Obviously, they have some allergies, eye rubbing. They want to get rid of their contact lens or glasses, and then they seek refractive surgery. And when you do the scans, you can find some amount of abnormality in the topography or reduced corneal thickness. So in very early cases like form frustrated keratoconus, low myopia and low myopic astigmatism improving to like 6/6 or 6/6 parts, then we can do a smile extra. This is something that I described almost 12 years ago, and we had the first publication where you can put riboflavin isotonic 0.25% in the pocket and then do the cross-linking for about 75 seconds. We do a 45 milliwatts for like 75 seconds. So it's a short accelerated cross-linking, and this we find that in our large cohort, I think more than 5,000 eyes which we analyzed, which was published again in the GRS, that those borderline cases where we did not do extra, almost about 8 of them over a period of time went into ectasia, but none of the cases with smile extra actually went into ectasia. So, but the thing is, you need to leave behind enough residual bed. You need to do the cross-linking, follow up these patients, and I would not advise it for moderate to high myopia, because there's no point in removing a lot of tissue and cross-linking it. It doesn't work. If lower myopias, less than like 5 diopters spherical equivalent, adequate corneal thickness, then you can do smile extra, and these patients are fine. So abnormal or borderline topographies, it works great. That's for early kind of. Then you have the moderate keratoconus. Moderate keratoconus is if there is some loss of best corrected vision, 6/9 or 6/12 vision, with glasses, and they are symptomatic. They have night vision issues. There we can actually do a topo-link PRK if the corneal thickness is adequate, along with the cross-linking. So that's the approach, and this works very well, especially if the cone is not too decentered. In axial cones, it works well. And then moderate keratoconus, K within 55, we have intrastromal rings.
Yeah.
If it is a decentered cone, then I like to use intrastromal rings. You can also do KERS. But if it's an axial cone, then I use my lenticules. I look at the spherical equivalent, correct for back vertex. Then we punch out the central 3 millimeter with a punch. So you have a donut-shaped lenticule. And then we put it into the pocket. We make a pocket in the cornea and then put it in the pocket and then cross-link it. Mm-hmm. And with this, we find the results are quite good. Stability is good. And the shape of the cornea improves from a hyperprolate shape to a more normal shape. So this is tissue addition using smile lenticules for keratoconus. Of course, we first published using lenticules for hyperopia, and it works very well, especially in that range between 4 diopters to 9 or 10 diopters, where there's no good treatment. Of course, you have phakic IOLs, but the anterior chamber depth is shallow in most of these hyperopic patients. And these are patients where they do very well with tissue addition, and you can treat up till 9 diopters, especially if you do a Bowman membrane relaxation technique, which again we have published in the JRS.
Yeah. Thank you very much for your time, and enjoy the rest of the meeting here.
Thank you.
Thank you.